We are going live in 5, 4, 3, 2, 1. We are live.
Good morning, friends. Welcome to Brain Teasers Season 2, Episode 8. This is the signature tune of our Brain Teasers for you. Yeah. Stop sharing. Good morning, friends, and wish you all a very healthy and a spirited new year to come. Welcome back to Brain Teasers, Episode 8 of Season 2. Let me introduce you all again to the concept of Brain Teasers. Brain Teaser is an edutainment initiative which was introduced last year by Sarakshi Netrale. This year, it has become a live online quiz which is conducted once a month on a web-based platform on first Sunday of the month. Also, it's no longer just a quiz, but much more. To increase your learning and knowledge, we have added new sections like Pearls of the Month, Wisdom from the Heroes in Ophthalmology, and to break the mundane, we have sections like Ophthalmic Humors, Shairis from our own ophthalmic brethrens. Season 2 began in the month of June, and till date, we have conducted 7 monthly quizzes. Brain Teasers also had the privilege to conduct quiz along with national societies like Delhi Ophthalmological Society, that is DOS, and Ocular Trauma Society of India. All these quizzes must have added to your knowledge, I'm sure. So friends, how was the last year? Answer is obvious for one and all. Yes, it was not so good. So now it's time to celebrate New Year and wish. It gives us a year full of fun, warmth, and health. But friends, do you know the significance of New Year and why is it celebrated? New Year is observed on 1st of January, the first day of the year on the modern Gregorian calendar, as well as it was celebrated in pre-Christian Julian calendar, pre-Christ era. In Julian calendar, the day was dedicated to Janus, the god of gateways and beginnings, for whom January is also named as. Now coming to the lens. Lens is the most important structure in the eye and probably the most important tissue in the whole body going under the scalpel of a surgeon. Still in our country, cataract has been responsible for 50 to 80% of bilaterally blind, and it affects till date even now 9 million people with cataracts. The COVID has put a break to the ambitious project of Vision 2020, that is right to sight, all in doldrums. So let us pledge in this new year to fight for this cause with renewed energy and vigor. And so is exactly the reason why we decided to have lens as the theme for the first quiz of this year, New Year 2021 for Brain Teasers. So aptly christened by our co-host as Lens-O-Meter. Today we have 3 special guests as our invitee. Padma Shri, Dr. Jeevan Titiyal. He's a professor and head Cornea and Cataract and Refractive Center at RP Center, Delhi. Welcome, sir. Another Delhi man, an innovator, Dr. Rajendra Prasad, called as Terminator. Not because he is lethally attacking like Arnold Schwarzenegger, but because he gave the world the technique of terminal chop. Welcome, sir. Our third guest is no other than Dr. Harsha Bhattacharjee. He's a director of Sri Sankaradeva Netrale, an unassuming man of few words. Welcome you all, sir. Today, I have 2 young Turks as my co-host. Dr. Divakant, a prolific vitreoretinal surgeon and a young dynamic leader of YOSI from Lucknow. And Dr. Bibbhuti Kashyap, a proud alumni of RP Center and another young vitreoretinal surgeon from Ranchi. Welcome you, Diva, as well as Dr. Bibbhuti. You will be my co-host for today. Yes, friends, we are available on Facebook and YouTube, where where you can retrieve previous as well as this program. Today, sharing the mantle with me is my co-host, Dr. Shilpi. Requesting now Dr. Shilpi to familiarize the participant with the rules of the game. Over to you, Shilpi.
Yeah, thank you, sir. So, good morning, friends. Wishing you all a corona-free new year. For the ones who have joined us for the first time, here are the rules for the today's quiz. Who can participate? Any ophthalmologist from a novice in ophthalmology, that is, a postgraduate, to the most seasoned practitioner. Remember, quiz has 5 sections with 5 questions in each section. Every question will have 4 options. Only one amongst the 4 is correct. So you have to first select the correct answer and also click the save button to record your answer. If you are not sure of the correct response, don't be in a hurry to press the correct response, as once you click the save button, you cannot change your answer. This is what the participants will see on their screen. This is a sample question for your understanding. Identify the character shown in the picture below. Option A, Tom. Option B, Jerry. Option C, Donald. Option D, none of the above. This timer will start for 20 seconds and you have to record your response only after the timer starts. Now here, the answer is B. So first you have to click this B button and then also press this save button so that your answer will be recorded. So who wins the prize? Naturally, the one who answers correct and importantly answers first, that is the fastest finger first. So what are the prizes? We have one section winner, so it means in total we have 5 section winners. And that's not all. For every session of 25 questions, we have 2 mega prizes, one for the runner-up and one for the winner. That means in total we have 5 section winners, 1 runner-up and 1 winner. So what is for the tiebreaker? If there is a tie for a section, the cumulative performance of all the 5 sections will be considered. But if there is a tie for the session winner, that is the runner-up and winner, dice will decide your fate. But remember, you can be section winner only for the one section, but don't give up, as you can win the session prize with your consistent performance. In case of any discrepancy, judges' decision will be the binding. So, what are the prizes? Prize money of rupees 1500 for every section winner. Runner-up will get the prize money of rupees 5000 and the winner will carry away the prize money of rupees 7000. It's not only the gifts. Winners, you will be invited for the concluding ceremony where you will share the screen and interact with our today's guests who are the who's who in ophthalmology. So winners, be alert. You will be sent a Zoom link as well as you will get a call on your registered mobile number. You need to join the platform as soon you get the confirmation. Now, I invite Dr. Divakant Mishra sir, who has got the training in advanced retina surgeries from Byers Eye Institute, Stanford University, San Francisco, and Sri Shankara Deva Netralaya, Guwahati. He is the recipient of various international ophthalmic awards like Achievement Award by Asia Pacific Academy of Ophthalmology, Ophthalmic Hero of India, Star of India Award 2020, the APVRS Award by Asia Pacific Vitreoretina Society, Indian Journal of Ophthalmology, the Best of Best Award. He has 30 publications and book chapters to his credit. He is reviewer of PLOS ONE, IGO, and IJCEO. He is the invited faculty at various international conferences like AO, APAO, URetina, and ASCRS. So over to Devakant sir for the further proceedings.
Thank you so much, Dr. Shilpi, for such a kind introduction. And at the outset, I would like to thank Dr. Prashant sir and his whole team of brain teasers for this wonderful concept. And at YOSI, we have conducted online quizzes, and we know how difficult it is to get this done. And I'm very impressed by the smooth functioning of this platform. So let's start the quiz, and this is the first section. Let's warm up. I hope all of you are ready. You are all well aware about all the rules that Dr. Shilpi has told us. Let's move on to the section 1 with the question number 1. So question 1 is, how old is the first documented case of cataract throughout history? Your options are option A 2400 BC, option B 1400 BC, option C 400 BC, and option D 40 BC. And your 20 seconds start now. So the main thing to focus here is the first documented case of cataract. A small hint is that it is from the Egyptian history. So your time is about to end. Okay, let's move on to the answer. The answer is option A, that is 2400 BC. So the image that is shown here, if you look at it, the left eye, we can see a white reflex, a leukocoria. So it is thought that this sculpture, which dates back to 2400 BC, is the first documented case of cataract from Egypt. And there are a lot of instruments related to eye surgery also found during the excavation. So that establishes, and it is the first case of cataract in documented history. So let's move on to our second question now. So are you all ready? Let's go to the second question. So name the French ophthalmologist who performed the first modern cataract extraction on April 8, 1747. Let's see the options. Option A, Jacques Daviel. Option B, John Taylor. Option C, Albert von Graefe. And option D, John Louis Bosch Jr. And your 20 seconds starts now. A hint would be here that he was a French ophthalmologist. So he was the first person who performed the modern cataract extraction, and we are not talking about couching here. So your time is about to end. Let's see the answer. So the answer is Jacques Daviel. So of course, he was a French ophthalmologist, and he is credited to perform the first modern cataract extraction. And we are not talking about couching here. And he used a variety of instruments like the corneal knife, forceps, scissors, a blunted needle, spatula, and a spoon. He made an inferior incision, and the cataract was gently pushed with the help of his fingers out of the anterior chamber and onto the cheeks. And then the eyes were bathed in a mixture of water and wine. And then a cotton dressing was done, and the patient was required to lay on their back in a darkened room for approximately 8 days. It sounds a lot like modern day retina surgery. So let's move on to the question third. Who performed the first documented intracapsular cataract extraction in 1753? The options are Jacquin Barriquer, option B, Samuel Sharp, option C, Bradford Shingleton, and option D, Luther Fry. And the time starts now. So this is about the intracapsular extraction now, and it happened in 1753. So time is about to end, just 3 seconds more. Okay, let's look at the answer. The answer is Samuel Sharp. So in 1753, Dr. Samuel Sharp was credited to perform the first documented case of ICC. And of course, the entire lens and the lens capsule is removed through a large limbal incision here. And Samuel Sharp also used his thumb to expel the cataract from the eye. For learning purpose, there are other methods of ICC like the Smith's method, the Arugas method, the Erici fakes, where a suction probe was used then cryosurgery, where cryo is used, and of course the chemical dissolution of zonules as well. Let's move on to our next question. So can opener capsulotomy was developed and popularized by option A, Dr. Little and Dr. Sinsky, option B, Dr. Nguyen and Dr. Gimbel, option C, Dr. Kimiya Shizumu, and Dr. Kelvin D. Furco. And your time starts now. All these doctors are associated with capsulotomy in one way or the other. That's why it makes it a little confusing. Last 5 seconds remaining. Okay, so the time is up. Let's look at the answer. The answer is Dr. Little and Dr. Sinsky. So we know Dr. Sinsky's name from the Sinsky's hook, and both of them popularized and developed the can opener capsulotomy, which was the standard of care for a long time. But all of us know the disadvantages. The capsule tends to tear in such cases. So then in early 1980s, Dr. Furco began using the tearing method, which is the principle behind the Calvinula rexus. But he is like a forgotten hero, and Dr. Thomas Nguyen described this technique in more detail, and which was further popularized in America by Dr. Gimbel. So these three techniques, at least all residents should remember: the can opener, the envelope technique, where a linear incision is made in the capsule, and the CCC. Let's go on to the last question. Who co-founded the Intraocular Implant Club in 1966 along with Dr. Harold Ridley, which was responsible for the gradual acceptance of artificial lens implantation? This person also developed several models of IOLs. Let's look at the option. Option A, Peter Choice, Dr. Richard Kratz. Option B. Option C is Dr. Elbert Galland, and option D, Dr. Thomas Nguyen. And your time starts now. We all know Dr. Harold Ridley well, but this other person should also be learned about. 5 seconds are remaining. Let's look at the answer. The answer is Dr. Peter Choice. That is option A. So Peter Choice was a student of Dr. Harold Ridley, and they together founded the International Intraocular Implant Club in 1966. And why we are talking about them is because this club was responsible for the acceptance of artificial lens implantation. And later on, Peter Choice developed various IOL models, and his Choice Mark 9, which was manufactured by Rayner Intraocular Lenses, became the first US FDA approved IOL in 1981. So Dr. Harold Ridley has been a pioneer, and he's the person who is credited with the first IOL implantation. And the interesting story behind that is that one of his residents stimulated him for this idea. And during one of the lectures, he talked about why can't we place an artificial lens inside the eye. And then he was treating a lot of fighter pilots, and they had come with PMMA sharpeners inside their eyes, and he found that these materials were inert and well accepted by the fighter pilots, and later on he used PMMA as the material. So this is the end of section 1. And now the section 2 will be taken care by Dr. Bibbhuti Kashyap. And let me introduce him. He's a very exceptional and bright young ophthalmologist and surgeon. He's the Deputy Director of Kashyap Memorial Eye Hospital, Ranchi. And his area of specialty is vitreoretina, uvea, ROP, cataract, and refractive surgery. He has trained from the best of the best. He's his post-graduation and senior residency from RP Center AIMS, and he followed it up with an oncology and medical retinal fellowship from Italy. And he's done a lot of surgeries and is a very exceptional person. Over to you, Dr. Kashyap.
Thank you so much, Dr. Divakant, for such a kind introduction. Now, it was a very informative section 1 for me as well. Now, I hope the viewers and the participants are all warmed up for section 2. So without wasting further time, we'll start off with the first question of section 2. Am I audible clearly?
Yes, Bibbhuti.
So the first question of section 2 is, the lens nuclei is retained in all of the following except. The options are A, chromosome 13 anomaly, B, rubella, C, Peters anomaly, or D, Loeys syndrome. And your time starts now. Time's up. And the correct answer for this question is Peters anomaly. So Peters anomaly is a disease among constellation of diseases causing congenital corneal opacity due to anterior segment dysgenesis by means of faulty migration or separation of neural crest cells. As we all know, there are 3 waves of neural crest migration. That the first wave forms the endothelium, the second wave forms the stroma, and the third wave forms the iris. So any problem in the migration of or separation of these causes these kind of anterior segment dysgenesis. So type 1 is the one that affects the iris, corneal endothelium, and the Descemet's membrane. And the type 2 has additional lens abnormalities. The lens may be abnormal, but the lens nuclei is not retained in these anomalies. The second question, all of the following are features of persistent hyperplastic primary vitreous or PHPV, except A, it is unilateral, B, it is hereditary, C, it is associated with microphthalmos, and D, it is one of the common histopathological findings in enucleated eyes of suspected retinoblastoma. And your time starts now. Time's up. And the correct answer is hereditary, option B. So persistent hyperplastic primary vitreous or persistent fetal vasculature is a rare congenital developmental anomaly where there is failure of embryological primary vitreous and hyaloid vasculature to regress. Has 3 forms: purely anterior, purely posterior in the form of falciform retinal septum, or a combination of both. It is mostly unilateral and non-hereditary and is associated with microphthalmos. And along with Coates disease, it is one of the most commonly missed diagnoses in eyes enucleated for a wrongly diagnosed retinoblastoma. It's worthwhile to know that mistakenly done enucleation rates are as high as 1.5%, and these are the diagnoses that you find in such mistakenly enucleated eyes. So coming to the third question, microspherophakia is associated with all except. Options are A, small stature, B, Alport syndrome, C, rubella, and D, hyperlysinemia. And your time starts now. Time's up. And the correct answer is hyperlysinemia. So microspherophakia is basically, as the name suggests, a lens which is a very small diameter. It is usually bilateral condition and there is increased anteroposterior diameter. The equator of the lens is visible with full mydriasis and there is movement of the lens with change in posture. The other abnormalities associated with this microspherophakia is lens dislocation or subluxation, high myopia, defective accommodation, and glaucoma. This is a list of various associations of microspherophakia, and hyperlysinemia fares pretty much very lower down the list and has been reported only in 1 or 2 case reports. Coming to the fourth question, a type of cataract seen in Hallermann-Streiff-Francois syndrome is A, sutural cataract, B, membranous cataract, C, anterior polar cataract, or D, pyramidal cataract. And your time starts now. Time's up. And the correct answer is B, membranous cataract. So Hallermann-Streiff-Francois syndrome is a rare sporadic anomaly which results in frontal prominence, small beak nose, baldness, progeria, micrognathia, pointed chin, hypodontia, short stature, and a narrow upper respiratory airway. And the type of cataract associated with this syndrome is membranous white cataract. So coming to the last question of the section, all are true for anterior lenticonus except A, it is associated with Waardenburg syndrome. B, it is associated with spina bifida. C, it is usually bilateral. And D, it is usually congenital. And your time starts now. So we need to answer which is not true for anterior lenticonus. Time's up. And the correct answer is D. It is usually congenital. So anterior lenticonus, as the name suggests, is the localized anterior conical bulging of the anterior lens capsule as compared to a posterior lenticonus, wherein, as the name suggests, there is posterior bulging of the posterior lens capsule focally. So anterior lenticonus is usually bilateral and acquired, not congenital. It is associated with Alport syndrome, spina bifida, and Waardenburg syndrome. Posterior lenticonus, on the other hand, may be associated with Loewe syndrome, and there are various clinical signs like fishtail sign and Atoll sign described intraoperatively and preoperatively for diagnosing posterior lenticonus. Anterior lenticonus may pose a surgical challenge in successful completion of continuous curvilinear capsular access due to the central cone. And in such cases, maneuvers like starting rhexis from mid-periphery and incorporating the cone or doing a lens matter aspiration before the rhexis has been described. To tackle a posterior lenticonus surgically, same maneuvers approximately as that for posterior polar cataract are employed. So with that, we come to the end of section 2. And meanwhile, as the backhand team starts computing the result for section 2, we go in for a break, the intersectional break. And in the meantime, I would take this opportunity to introduce the first guest of today's session, Professor Jeevan S. Titiyal. He is the professor and head of cornea, cataract, and refractive surgery services at RP Center, AIIMS, New Delhi, and is also the chairman of National Eye Bank. It is an honor to introduce and speak about such a stalwart of Indian ophthalmology, more so on a personal level as he was my guide for my PG thesis. He is someone who every resident in RPC tries to emulate in their cataract surgeries, whether it be his machine settings or his technique. As they say, if you have the perfect role model, your job is half done, and Professor Titiyal fits that bill just perfectly. He has over 290 publications in peer-reviewed journals. He has been involved in multiple international instruction courses. He was the first Indian to perform live surgery at ASCRS USA. He has multiple international and national honors to his name, including the coveted Padma Shri by the President of India in 2014. He is the past president of Delhi Ophthalmic Society in 013 to 014 and is currently the president of ISCKRS since 016. And now it's time for his Pearl of the Month. I'm going to stop the screen sharing from my side.
The management of post-polar cataracts.
Sai, go back to the video. सही एनी प्रॉब्लेम तेरे से प्ले हो पाएगा आपल्या ह्याच्यात आहे का माझ्या ह्याच्यात इनकॉर्पोरेटेड आहे माझ्या ह्याच्यात आहे. सही shall I do it from my end?
Yeah, please, doctor.
Yeah, 1 minute. आपल्याला शेअर स्क्रीन करना पहले
प्रेजेंटेशन तो निकालने दो सेक्शन 3 डाल इस नाम से नहीं मिलेगा
सेक्शन 3
नहीं मिलेगा उस नाम
सेक्शन 3 करना
नेक्स्ट इसके नेक्स्ट
लेकर आते हैं
शेयर स्क्रीन तो करो
is it visible?
Yes, doctor.
Slowly.
The management of posterior cataracts is surgically challenging owing to the high incidence of posterior capsular adhesions. Pre-operatively, posterior cataract may be classified on slit lamp examination into 4 tags. In addition,
I don't know. What happened? What has happened?
मेरे से
तेरे से पूरा प्ले हो रहा था
Prashant, you can ask Dr. Titial to share his screen.
Yeah, I think so.
Better,
Titial sir. Hello. Dr. Titial sir. Hello. I don't know.
Shall I try sharing the screen?
Yeah, please do. Titial sir, are you there?
I'm there.
Do you have presentation on your laptop, sir?
I'll have to download myself, it's in my
Okay, we'll try
email.
meanwhile, we'll try, sir. I'm sorry for the...
My net is also little today, not doing well.
Okay, okay. We are trying, sir. Meanwhile, I will try through the other laptop. Shilpi?
है क्या कितने आंसर का है पक्का शेयर करना Zoom meeting in huh?
The management of posterior cataracts is surgically challenging owing to the high incidence of posterior capsular adhesions. Pre-operatively, Posterior polar cataract may be classified on straight-line examination into 4 types. In addition, anterior segment OCT may help to delineate the size and shape of posterior polar opacity, intactness of PC, and detect pre-existing PC defect. Conventionally, hydrodissection is avoided in posterior polar cataract. Multiple hydrodelineation rings are created and a layer by layer or a slow motion phacoemulsification is performed. Avoidance of hydrodissection leads to difficulty during cortical cleanup, and any stress on the fragile posterior capsule can lead to a PC defect during irrigation aspiration. Intraoperative OCT or IOCT provides a real-time dynamic insight into the intraoperative manipulations. 3 morphological variants of posterior polar cataract were observed in IOCT. Type 1, posterior polar cataract were characterized by an intact posterior capsule clearly visualized along the entirety of posterior polar opacity and a clear homogeneous space between the posterior capsule and the hyperreflective posterior polar opacity. Type 2 posterior polar cataract was characterized by an intact posterior capsule observed in the periphery of the opacity. Posterior capsule could not be clearly delineated in the entire posterior polar opacity, with the dense central region of opacity apparently adherent to the posterior capsule. Type 3 posterior polar cataract was characterized by dense posterior polar opacity with extensive shadowing and an inability to delineate the posterior capsule status in the entirety of the opacity. In type 1 posterior polar cataract, after capsular access, hydrodelineation was performed using a blunt 27 gauge cannula. The separation between nucleus and epinucleus with formation of an epinuclear cushion was visible as a hyporeflective region on IOCT. After hydrodelineation, a gentle hydrodissection was also performed in type 1 posterior polar cataract. The passage of fluid wave resulting in a separation of posterior capsule and cortex was observed in IOCT, and the integrity of posterior capsule was assessed. The epinuclear cushion was maintained throughout the nuclear emulsification in all cases, and an intact PC was visualized at all steps of surgery. The cortical matter was gently peeled off from the posterior capsule, starting from the periphery towards the center. A foldable intraocular lens was implanted in the bag. No case with type 1 posterior polar cataract developed an intraoperative posterior capsular defect. In type 2 and type 3 posterior polar opacity, only hydrodelineation was performed in all cases and hydrodissection was avoided. The cleavage plane created by hydrodelineation waves were visualized in IOCT. The intactness of epinuclear cushion was assessed during nuclear emulsification. 3 eyes developed posterior capsular adhesions during the stage of aspiration of epinuclear cushion. 1 eye with type 2 posterior polar cataract and 2 eyes with type 3 posterior polar cataract. IOCT helps in risk stratification of posterior polar cataracts based on the morphological features. Preoperatively, anterior segment OCT may be used for morphological characterization of posterior polar cataracts. Intraoperatively, IOCT aids in decision-making regarding whether or not to perform hydrodissection. We demonstrated safety of performing hydrodissection in cases with type 1 opacity.
Bibbhuti, over to you now.
So thank you so much for such a technologically innovative video, sir. If I may request you to please come live with us. So
Yeah,
it was a brilliant study and a new classification system, intraoperative and preoperative. Sir, but I have a few questions on behalf of the general ophthalmology audience and the postgraduate residents who are very early on in their career. So at centers, sir, which don't enjoy the privilege of an intraoperative OCT, do we have some clinical signs on slit lamp maybe to predict a pre-existing posterior capsular discontinuity, which may alarm us for a possibility of an intraoperative PCR?
Yeah, first of all, Bibbhuti, thanks for our invitation, and welcome all the people who joined today in your brain teaser session. And my best wishes for this year 2021. As we going into a cataract session, I think posterior polar cataracts, as you rightly pointed out, does give a challenge in the intraoperatively to maintain the posterior capsular integrity. Therefore, it is one of the most important case in cataract group where you require a very good pre-op examination, and that too, with the full examination under dilatation. And if you do look into straight time examination, that can delineate most of the cases, as you could see in a more objective way in an anti-segment OCT also. But slit lamp, you have to see few things. One is the size of opacity, because larger the size, you have more chances of adherence to the posterior capsule. So size is very, very important. Anything more than 3.5 millimeter has a higher risk of posterior capsular adhesions. Second is the density of opacity also. That is the reduplication which happens towards the anteriorly from the posterior part of the this opaque disc. So that is also important. Third is the grade of a nucleus hardness. If you have a softer cataract, that means patient has come to you early. So adherence towards the posterior capsule may be less likely in these cases. So you have a hardness, harder the nucleus, you have more chance of posterior capsular adhesions happening. The other important thing is if you could visualize the posterior capsule beyond the posterior capsule, that is the anterior vitreous phase. So sometimes you can pick up a telltale signs, which may be a little bit of granulation happening just behind the lens capsule, which may point towards a deficient posterior capsule in these cases. Or in a congenital cases, you can have a fishtail sign. So what we are talking about, these are adult type of posterior polar cataract. They are totally different than a congenital posterior polar cataract. That I think PGs have to understand. And both require a different type of assessment and management. As far as the finding which I told you in our slit lamp can be reduplicated or a more objective way by anti-segment OCT, which we see in IOCT also. And you can know the status of a posterior capsule very, very clearly in these cases. And beyond the posterior capsule also you can see very nicely, and then plan your surgical technique or a surgical manipulations or a phaco parameters accordingly.
Yes, there was also a sign described by Dr. Daljit Singh where he said that if there are mini satellite cataract cataractous opacities around the central disc of a posterior polar cataract, that denotes usually a deficient capsule because and he hypothesized that there is entry of aqueous through that deficient capsule causing multiple opacities around that. So what is the utility of that sign in your experience, sir?
As far as I'm concerned, all features of anything beyond the disc may point towards some sort of changes happening in the posterior part of the lens nucleus cortical complex in relation to posterior capsule. Yes. And these peripheral changes normally doesn't affect the posterior capsule at all. It is a central disc, which is the major part, which may have a relationship towards the posterior capsule. Either it is attached to the posterior capsule, or there may be a deficiency of posterior capsule. So one of our articles is just going to come in JCRS, where we have hypothesized the entire process of this disc formation. Whenever you have a posterior capsular disc coming up, which starts from the posterior poles towards the center of the nucleus, the peripheral cortical fibers, they get disaligned from the disc. That's why if you saw my one of the videos has a classical central disc defect. So that explains it is the central area which is important, not the peripheral areas. Yes. And once you have this defect seen, that means your PC is intact. Only the disc has come out during your nucleus emulsification. So that explains the concept of a posterior polar cataract formation and the safety of posterior capsule also. So peripheral opacities, though it will increase the size, but normally they don't have attachment. It's the central area which has the attachment.
So very rightly said, sir. And so one more question that the postgraduates usually ask us who are novice to, who are pretty new to the phacoemulsification and beginning to operate these sort of complicated cases. So can you guide them as to what should be the size of capsular excess in the posterior polar cataract? Should it be slightly smaller than normal to ensure a good sulcus so that in case of a PCR, you have a good sulcus for multi-piece, or should it be larger than normal to prevent the fluid trapping and sudden increase in the back pressure? To cause a PC defect. So what do you, according to you, what should be the size?
I think Bibbhuti, very, very nice question, because a lot of whenever we talk about cataract surgery, many people have different thoughts and different ways to handle same type of cases. And as far as capsular excess is concerned, it has to be ideal size. That means it should not be too big to not to allow lens edge to be covered by these capsular excess margin, which is the concept of in the bag implantation. Or should not be too small to have a difficulty your nucleotomy also. The ideal size in a posterior any cataract surgery would be around 4.5 to 5.2 millimeters. Here also, I would recommend to have a normal size capsule excess. Don't make it too small or don't make it too big, because the lens optic size is 6 millimeter, whichever lens we are putting. And most often you'll be putting in the sulcus. So that is a 12.5 millimeter, 30 millimeter overall diameter. It will retain whatever size capsule excess you have made. So don't worry about the concept of not having a support. It is the having a better surgical aspect of a complicated case. There has been a concept of doing a oval capsule excess also, especially from Dr. Kiranjit Singh from Amritsar. I normally there also, the oval size also, the largest diameter doesn't cross more than 5 millimeter. So that is the concept also. Don't make it too large, which is more than 6 millimeter. That makes the surgery more difficult also sometimes, because nucleus can tilt and bulge it out sometimes. And putting your important premium lens in these cases will be very, very unideal in such situations. The excess should be ideal size of 4.5 to 5.2 millimeter.
Thank you so much, sir. You just proved it why people try to emulate you always. I think this is it from this section. So, Prashant, sir, can we go to announcing the section winners?
Yeah, I think it is in your chat. Please go ahead.
Yeah, Dr. Divakant, sir, for the section 1, please do the honors.
Thank you so much, Dr. Bibbhuti. Thank you so much, Titial, sir, for such a wonderful presentation and all the question answers. So the section 1 winner is Dr. Sohini Mandal from New Delhi. Congratulations, and you will be receiving a link on your mobile. Please join in and keep playing for the rest of the sections to be the segment winner today. Yeah, Dr. Bibbhuti, the next.
Actually, she's working in my unit only now.
Okay.
She's my new SR.
And the section 2 winner for today is Dr. Ayushi Sinha from New Delhi. Congratulations, Dr. Ayushi Sinha.
Wonderful, wonderful.
Over to you, Dr. Divakant, for section 3, please.
Yeah. Just a second. Okay. Thank you so much, Dr. Bibbhuti. And let's move on to section 3. We have two very exciting segments. Now to section 3, the first question. Okay, let's move to basics. True about the adult lens. Your options are: A, shows a greater curvature of the anterior surface than the posterior surface. B, shows an average thickness anterior to posterior of 4 mm. C, is held in place by zonular fibers arising from the posterior iris. And D, has an equatorial diameter of about 10.5 mm. And the time starts now. Please read all the options really carefully. Five seconds to go. and your time is up. So let's look at the answer. The correct answer is option A. It has a greater curvature of anterior surface than the posterior surface. Let's see why. There are a lot of data. Let's look it through a diagram. So this is, I got it from the eOphtha website. It's a very good schematic representation. So the anterior surface is less convex, thus has a greater radius of curvature of approximately 10 mm, and the posterior is more convex and hence a lesser radius of curvature of around 6 mm. Now the thickness of the anterior posterior diameter is approximately 3.5 mm at birth, but it keeps on increasing by 0.02 mm each year throughout life. And the equatorial diameter or the lens diameter is 6.5 mm at birth, and it increases to 9 mm in the second decade, and then it remains more or less constant throughout life. Okay, now let's move on to question 2. Now, true about the change occurring in an aging lens. Your options are: option A, the oldest lens fibers are externalized; option B, absorption of ultraviolet wavelength increases; option C, a yellow pigment is deposited in the posterior cortex; and option D, posterior migration of the lens epithelium causes nuclear changes. And your time starts now. It's really important to know about the aging lens. Five more seconds to go. And your time is up. Let's look at the answer. The correct answer is B, absorption of ultraviolet wavelength increases. Now the lens epithelia turns inwards at the equator and elongate and constantly forms new lens fibers, and thus internalizes older lens fibers rather than externalizing them. Then the yellowish pigment is deposited in the nucleus and not in the posterior cortex, and can keep on absorbing ultraviolet light. Then posterior migration of lens epithelium causes posterior subcapsular cataracts and not nuclear changes. So I think that's sorted. Let's move on to the question number 3. True about the capsule of normal adult lens. And your options are: A, it is the thickest basement membrane in the body; B, produced continuously for only approximately first 35 years of life; C, it is thickest at posterior pole of the lens; and D, includes major structural proteins like type 2 collagen, laminin, heparin, etc. And time starts now. So you have to tell what's true amongst these 4 options. Read all the options really carefully before going for the answer. Just 5 seconds more. And your time is up. Let's look at the answer. The correct answer is A. It is the thickest basement membrane in the body. So lens capsule, which is a transparent membrane that surrounds the entire lens, is thickest basement membrane in the body, and it is the thinnest at the posterior pole, and is produced continuously throughout life. And type 4 collagen is one of the main, and in the options it was mentioned as type 2. So let's move on to the 4th question. It's about the lens epithelial changes can cause cataracts by. Your options are: A, metaplastic changes resulting in anterior subcapsular cataract; B, migration posteriorly resulting in equatorial subcapsular cataract; C, production of toxins causing nuclear sclerosis; and D, anterior migration causing posterior cortical cataracts. And your time starts now. Halfway through. Last 5 seconds remaining. And your time is up. Let's look at the answer. The correct answer is A, that is metaplastic changes resulting in anterior subcapsular cataract. Let's look at the explanation. Now, the anterior subcapsular cataract is usually anterior trauma, blunt injury, or anterior uveitis, which leads to metaplastic changes. Now, in case of posterior subcapsular cataract, there is posterior migration of the lens epithelium, And in nuclear cataracts, there is compaction of lens fibers and deposition of the pigment, and it is not from toxins. And the last option, that is anterior subcapsular cataract, there is anterior migration of the lens epithelium. So let's move on through the last question. Which of the following is not an in vivo cataract classification system? Your options are A, lens opacity classification system, option B, the Oxford system, option C, WHO's simplified cataract grading system, and option D, lens grading system. And your time starts now. So which one is not a cataract classification system? Last 5 seconds remaining. Okay, and let's look at the correct answer. The correct answer is D, lens grading system. There is no such system at present. And see, this is what the LOCS plate looks like. So there are various systems that have been developed for better grading of cataracts, and which are mainly used for research purposes, like the LOS, various types of the LOS systems. And the other system that we should know about is the Wilmer system, the Oxford system, the WHO one, and the Japanese system as well. So that is the end of this round. And I'll move on to we have another guest with us today. We'll be declaring the winners after this talk. And I have the proud privilege of introducing Dr. Harsha Bhattacharjee. He has been my mentor, and like me, for many ophthalmologists from Northeast India and from around India, he has trained them. So he's the president and trustee of Sri Shankadev Netralaya Guwahati. And this organization was declared as Center of Excellence in 2004 by Dr. Manmohan Singh, who was the then Prime Minister. And Dr. Bhattacharjee has various awards and presentations and publications to his credit. And he's an examiner at various universities, including the Royal College of Surgeons. And he has been a pioneer in the Northeast. He was the person who brought in intraocular lenses, modern cataract surgeries. He introduced phacoemulsification, and he also introduced vitreoretina setup to the Northeast. So, sir, may we have you live with us?
Yes.
So, thank you, sir. So I'll be playing your slides, and yeah. So just before sir starts, so sir had some issues with his laptop, so he won't be able to present his videos, but he has been very gracious in coming here and will be speaking through these slides.
Thank you, Dr. Divakant. And thanks to the organizers and those who are participating.
A bit louder, closer to the system.
So you can turn on your video as well, sir.
And those who are participating in the today's meeting. It's a very interesting meeting. I think all the participants will be immensely benefited. Now, what I will be going to tell you, it is nothing new. A particular complication has occurred previously, decade onwards, now also, and it will continue in the future. Next slide. The posterior capsular rupture, you go on clicking. Next slide. Is a major intraoperative complication, and the literature say it can occur in 1 to 4% of cases, even in expert hands nowadays. Proper management, if it can be done, it results in a desired visual outcome, and otherwise the result can be disastrous. Next. It doesn't warrant panicking, but requires a planned approach. Next slide. Every phacosurgeon needs adequate training for this proper management. So PCR can occur during many stages of cataract surgery. One common situation is the capsular axis, particularly if it is a intralenticular pressure is high, it can extend. During the time of hydrodissection, if the capsular axis is smaller, overhydration, or if there is a PPC, as already Dr. Titial has told, if the properly case is not assessed before the surgery, maybe during the lens nuclear fragmentation, and these are the when even the fragmentation has been performed, then the cortical aspiration is done. At that time also the PCR has been seen. Next slide. So another point to remember, this particular complication can occur with or without vitreous prolapse. Vitreous prolapse means the vitreous can come into the anterior chamber. Our today's discussion, as the time is very much limited, PCR during the lens fragmentation. What happens actually? When PCR is possible, when the last fragments are removed, when the PC is unprotected, and there is an attempt to remove incompletely separated lens fragments, and we are need to know the punch hole sign, identification of the punch hole sign to prepare to take proper protection before the disaster occurs. I should not say disaster, provided the complication occurs. And sometimes the PCR has occurred early, but it is detected during the lens fragmentation. Next slide. Now, first of all, we have to know how to prevent the PCR. We have to know how to do a proper hydrodissection. Next slide. What will be the proper capsular exercise, as it has already been mentioned. And when mechanically we divide the lens by the chop technique or any other technique, at that time, if the proper methodology is not followed, the PCR can occur. Now, sometimes the phaco probe is not kept in the same zone. They are very close to the posterior capsule. So even it can cause, the ultrasound itself can cause a PC rupture. Now, the phaco machine to be set with proper dynamics, with the proper titration of ultrasound, fluidics, and LOC grading has to be done. What type of strategy will take up? Now, what are the possible presentation of PCR when the PCR occurs during the lens fragmentation? It may be a small or large PCR. Small PCR means if it is located in the central part about 2-3 millimeter area, and if it is beyond than this, we can cause a large PCR. And as I said, the nuclear fragment may remain or may not remain, or very little amount of nuclear fragment remain, and these fragments may be small and large. All these points are to be considered. And we have to ascertain vitreous prolapse is there in the anterior chamber or no vitreous prolapse in the anterior chamber. Next slide. Fourthly, the fluid may diverge inside the vitreous cavity. The pressure inside the vitreous cavity can increase. So the direction of the fluid should be toward the angle of the anterior chamber after the PCR has occurred. Otherwise, the fluid may go inside the vitreous cavity and cause expulsion of further vitreous, and the lens fragment may drop inside the vitreous cavity. So these are the possible presentation may we encounter. The steps when PCR is recognized. When we recognize the PCR has occurred, our objective is to prevent the collapse of the anterior chamber and the prevention of enlargement of the lens and maintaining the shape of the globe in its physiological condition. As we have seen n number of times, if the PC is convex, then it is very tough, very taut. We can polish the capsule, we can do the capsule, many things we can do. But if it is concave, bulge forward, it is the weak because of the physiological property of the posterior capsule. Normally, it is deviating behind until unless there is some congenital defect in the development of the posterior capsule. The posterior capsule is very tough, and if the chamber is maintained properly and the proper methodology for phacoemulsification is followed, then the chance of PCR is reduced. So our objective is to prevent the collapse, to prevent the enlargement, and maintaining the globe in shape. Stop the phacoemulsification as well as the aspiration, only maintain the irrigation. Then with the side port, fill the anterior chamber with dispersive viscoelastic substance and remove the handpiece carefully. So these are the essential steps a surgeon have to do. A surgeon have to do when the PCR has been recognized. So 1, 2, 3 step we should remember. There is no question of panicking because I have already said the PCR occurs in the expert hand, in the resident hand. But if the methodology of management, standard protocol is there, if it is followed, then PCR is nothing to be worried. You will give the predictable visual outcome. Even the patient will not be knowing something wrong has happened. Then proceed further. Be sure the surgeon knows it or not, whether he's trained on management of the PCR or not. If not, then don't try. Take help of the others who knows it. I believe this is the most important step considering the safety of the patient, because a person who knows the technique, he will give a very unpredictable result. Then if the vitreous is prolapsed, identify, and the vitreous has to be managed very, very meticulously. Next slide. The management of residual nuclear fragment. When there is no vitreous in the anterior chamber, in the viscofield eye, anterior chamber manipulate the lens fragment away from the rent. Emulsify the lens fragment. Use copious viscoelastic to both protect the corneal endothelium and viscodispersive viscoelastic you can use here, and tamponating the posterior capsular rent, you can use cohesive viscoelastic material. You emulsify the lens fragment. Be careful that you are taking proper protection to the endothelium and PC, and all your settings should be low. The ultrasound should be moderately high as per the nuclear grade, and fluidics, the bottle height, everything should be low, so that very gently the nuclear fragment can be removed. Now, if the piece is larger, the wound can be enlarged, and with a wire vitreous, it can be removed safely. Now, the second situation is that if the vitreous is prolapsed in the anterior chamber, then what we should do? Now, use irrigation plus vitrector in two separate port. If the vitreous is prolapsed, there is no alternative to switch over to vitrectomy system. And there are certain methods have been described. The irrigation and vitrectomy, two limbal incision you make, or you enlarge the side ports we have already made. In one port, you give the irrigation. I've already said the irrigation should be directed to the angle of the anterior chamber, not to the posterior capsule. And vitrector you use to do the further manipulation. Now, remove the vitreous with the vitreous cutter. A surgeon should know what will be the optimal setting of the cutter, what will be the cut rate, what will be the aspiration rate, and smaller gauge the vitrector. From my experience, I have seen if we can switch to 27 gauge, the procedure become easy because the fluid turbulence and the fluidics are not disturbing too much in the anterior chamber, and it is very safely the procedure can be done. If not available, then they can 25 gauge or they can use 23 gauge, but 20 gauge gives not very good successful result because the vitreous traction is more, the pulsatile vitreous traction is more, and the postoperative period, some retinal complication, there is a high possibility that may occur. Now, I've already told that tamponate the PCR with cohesive OVD and ultrasonic fragmentation of residual nucleus, the specification, I've already given the outline. Next slide. And bimanual, if the nucleus is not there, only the cortical remnant is there, then you do a bimanual aspiration, and the vitrectomy cutter is the best option. You can aspirate, and if you think the vitreous is captured, you put the cutter for some time. So aspirate and cut, aspirate and cut. You are in a completely safe condition. Next slide. Next slide. Now, we do anterior vitrectomy for managing such a situation. Now, what is the goal of the anterior vitrectomy? We remove the vitreous from the anterior chamber, because vitreous is not the normal abode of the anterior chamber is normal, not the normal abode of the vitreous. Now, if the vitreous is near into the anterior chamber, it can destroy the corneal epithelium. It can cause iris atrophy. It can cause repeated inflammation to the eye. It can cause even cystoid macular edema. It can give rise to retinal detachment if it is incarcerated to the wound. And we should always clear the vitreous from the anterior and allow the intraocular lens to be placed so that we cannot leave the patient aphakic. Now, what are the principles of removing the anterior vitrectomy? Now, I want to say one point. The vitreous has an attachment into the vitreous base. We have to clearly understand the retinal periphery is 100 times thinner than the central retina. And the collagen fibrils is elasticity and its tensile strength. It is sufficient to cause a retinal tear. Some tear may be undiagnosed, and after a few months, so when the vitreous tamponade will go, the patient will come with the retinal detachment. So we cannot endanger the patient life. We can make the procedure unsafe. So the proper methodology we have to follow. So remove the vitreous from its normal. What I mean to mean, the vitreous is in the vitreous cavity. So if you want to remove the vitreous, put the cutter underneath the posterior capsule. If you approach anteriorly, and if you think that pars-plana approach, you know it, or your colleague will come to pars-plana approach, so that will be a formal pars-plana approach. That point will come soon. But remember, we cannot mask anything. I have witnessed one surgery. The lens nucleus dropped and it was sinking. The surgeon is used to one wire vectis and he has scooped out the retina. This horrible experience, I tell all my students, so never do all this thing. Never. Now, phaco probe should not be there in the vitreous cavity. Next. Wire vectis never in the vitreous cavity. The fluid levitation by Charles Kelvin, that is also a dangerous thing. It also gives retinal tear. I have seen many cases. Next. And cellulose sponge vitrectomy is another dangerous thing. All the situation, what happens, the vitreous is attached to the vitreous base. We pull it, and the vitreous base is out of our sight and out of our mind, and we cause a retinal tear, and then patient come with a retinal detachment. I think all who are doing VR surgery, they are getting plenty of such cases. So this 4 maneuver, very dangerous. Never to put a wire vectis in the vitreous cavity, never to put a phaco probe, because many videos are there, but it is a very dangerous. One time we may be successful, but all the time in 100% procedure will not be successful. It's a very dangerous procedure. Sponge vitrectomy, cellulose sponge vitrectomy is another problematic situation. So like this, and fluid levitation. These 4 things for the historical interest or the development of the management of the drop nucleus, we can remember, but we should not follow this in our routine day-to-day life. Regarding the method, as I have told you, if the surgeon is trained with limbal incision, then he take a vitrectomy cutter. One side he will put the infusion, another side the cutter, and the vitreous is to be removed. first from the anterior chamber, then gently put the vitrector just behind the posterior capsule, and as it is a collagen 5 linking is there, so it will slowly pull all the vitreous. Even if you highlight it with the triumphs, you'll see from the wound it is coming. Never sweep the vitreous. Never sweep the vitreous. First you cut his link, then you can clean the wound. What I mean to say, some surgeons I have seen put a flat instrument and try to release the vitreous from the wound. Mind that one side it is attached to the wound, other side it is attached to the vitreous base. So we are pulling both the side, and that is the pulsatile vitreous traction. The pulsatile vitreous traction means we become desperate. At one point of time, it gives a very big pull, and it is sufficient to cause a small tear. And along with subsequent vitreous change, the patient will develop detachment. So what to be done? You cut it into the iris surface. So it's completely separated. Then you can remove with the wound, but sweeping should not be the primary procedure to release vitreous from the wound. Now, in single port pars plana vitrectomy, it is my choice. What we do, one port is there in the anterior chamber, the irrigation port, which is already the primary surgeon is put while doing cataract surgery when complications occur. The second port we make just 4 millimeter behind the limbus in the pars plana region, or 4.5 millimeter. We visualize the tip into the pupillary area. We take care that it is not touching the posterior capsule. Inject little amount of triamcinolone acetonide. This will highlight the vitreous, and from behind the posterior capsule, from the anterior vitreous way, the entire vitreous can be safely removed. We have done this procedure repeatedly many times, but every time the result is predictable. But what I want to say again, if the pupil is larger, they started cutting from the peripheral part. If the pupil is small, then there is no option out. We can cut the center. So if you forcefully introduce the cutter, that may also cause some problem into the vitreous base. So single port pars plana vitrectomy is a very good option. I think it should not be in the scope of the VR surgeon. This procedure, all the cataract surgeon must get some training, and at that time, if they have proper vitrectomy machine, they can manage it. Otherwise, the case can be set. I have never seen a lens fragment causing damage to the eye. If the cortex and vitreous mix is there, or a lens nuclear fragment retains for a longer period of time, more than 2 weeks, at the time there is some immunological response occurs and inflammation may occur. So ideally, within 2 weeks, the case to be managed. It can be sent to a VR surgeon, and patient to be informed that this complication has arrived. What we do in the preoperative counseling, we explain all the pros and cons, surgical complication. Most of the patient will not be taken a different way, because we'll be making sure that whatever vision recovery was possible following cataract surgery, we'll give the same sort of visual recovery, but you require a second intervention. Next slide. Now, if the lens nuclear fragment or lens nucleus goes into the vitreous cavity, I've already said no levitation, no wire vectis, no phacoprobe. The only one option is 3-port pars plana vitrectomy, and the removal of the lens nuclear fragment and the lens nucleus as per the standard and safe norms. So this much I want to highlight regarding the management of the if the PCR occurs during cataract surgery. I'm again telling you, it is never a panicky situation. We should not make our children frightened that is something serious. It is serious definitely, but it is manageable serious. Thank you for giving me the opportunity to take part in your wonderful meeting.
Thank you, sir. Thank you, sir. It was quite enlightening. Divakant, over to you.
Thank you so much, sir. And sir has answered all the questions that I had in my mind. And sir had to leave early, so we'll not hold him anymore. And thank you so much, sir, for such a wonderful presentation. And you are such an inspiration to all of us. And the words of caution that sir has given in his presentation that everybody should keep in their minds while tackling such cases. Thank you so much, sir.
Thank you very much.
Okay. So it's time to announce the winner for the last segment. And we have our first non-Delhi winner. So she's Dr. Prerna from Wardha, Maharashtra. Congratulations, Dr. Prerna. And please, you'll be receiving a link on your mobile, and please log into us and please keep playing for the next of the sessions to be the session winner. Now, may I invite Dr. Bibbhuti to share his screen and take on the next sessions.
Yes. Thank you, Dr. Divakant. So let me share my screen with you all. Now, next segment would include both section 4 and section 5 without an intersectional break. And after that, we have the third guest lecture. And after that, we'll be announcing the section winners of both the sections, section 4 and 5. And then session winners will be announced. To note that section winners should also continue playing because they also have a chance at winning the session. Yes, the section winners cannot win the section twice, but they're always eligible to win the session prize. So let's start with section 4. And the first question of section 4 is, a type 3 femtosecond capsulotomy is an incomplete capsulotomy, A; B, a capsulotomy with microadhesions; C, complete capsulotomy; or D, complete but non-continuous capsulotomy. And your time starts now. Time's up. And the correct answer is incomplete capsulotomy. So as we all know, femtosecond laser-assisted cataract surgery uses photodisruptive laser of wavelength 1053 nanometers to create corneal incisions, arcuate keratotomy, capsulotomy, and nuclear division. A capsulotomy in a femtosurgery is a microcan opener capsulotomy, while an ideal capsulotomy achieved is a type 1 or a complete capsulotomy. There may be morphological variations of capsulotomy that can also be achieved, amongst which type 2 is capsulotomy which still has microadhesions, type 3 which is the incomplete capsulotomy, and type 4 which is a complete capsulotomy but it is non-continuous. Now coming to the second question, the best IOL power calculating formula for post-LASIK eyes is A, Hoffer Q, B, Huygens, C, Holiday 1, or D, Holiday 2. And your time starts now. Time's up. And the correct answer is B, Huygens. So in order to choose the right IOL formula, we need to know which formula suits which eye. So for axial lens less than 19 millimeters or very short eyes, Holiday 2 is the preferred IOL formula. For axial lens less than 22 but more than 19, Hoffer Q is the formula of choice. SRK Holiday 1 is for eyes between axial lens 24.5 millimeters to 26 millimeters, and SRK T is for axial lens more than 26 millimeters. Now, Huygens is a fourth generation IL power calculating formula, wherein the IL power is given by the formula D is equal to A0 plus A1 AC plus A2 AL. A0 is the manufacturer's lens constant, A1 is linked to anterior chamber depth AC, and the value is 0.4, and A2 is linked to axial length measurements, and this is a constant number, the value is 0.1. So as we all know, with a LASIK, the keratometry values are changed and the relation of anterior curvature and posterior curvature is altered. As a result, the normal standard keratometry readings are always flawed and tends to overcorrect or undercorrect in myopics or hypermetropics. So that is why a formula which is independent of the K readings need to be taken in high gaze as a perfect example of that. Coming to the third question now, it's a factual question, not much explanation needed for this. Concentration of trypan blue used for staining lens capsule is A, 0.06%, B, 0.15%, C, 0.25%, or D, 0.20%. And time starts now. Time's up. The correct answer is 0.06%. So trypan blue can be used to stain the anterior capsule during cataract surgery as well as internal limiting membrane during ILM peeling. The concentration of trypan blue for anterior capsule staining is 0.06%, and for that for internal limiting membrane is 0.15%. Now coming to the fourth question, femtodelineation is employed for A, posterior subcapsular cataract, B, anterior subcapsular cataract, C, posterior polar cataract, or D, intumescent cataract. And the time starts now. Time's up. And the correct answer is posterior polar cataract, option C. Now, what is femtodelineation? It basically is done on a femtosecond platform, which, as discussed earlier, it uses a photodisruptive laser to create various incisions as well as nuclear division. So in the femtodelineation pattern on the femtosecond platform, multiple nuclear layers that act as shock absorbers during surgery is created. So these are all customizable, sharp and predictable layers of, and it provides predictable layers of cushioning to protect the posterior capsule until the end of lens removal. It is also useful in posterior polar cataracts with an associated dense nucleus because there is no need for a mechanical division technique that could stress the capsule zonular complex. Now, coming to the last question of section 4. If C is the cylindrical power of toric IOL, which has been misaligned by X degrees, then the resultant residual astigmatism R is given by the formula. Your options are A, 2C cos X, B, 2C sin X, C, 2C tan X, or D, 2C cot X. And your time starts now. As we all know, the most common nuisance of a toric IOL is misalignment or rotation. So this question is a factual question regarding that post-operative complication, if you can say. Time's up. So the correct answer is R is equal to 2C sin X, option B. So this is the formula to calculate residual astigmatism R in a misaligned toric IOL, which is misaligned by X degrees. So most rotations usually happen within 10 days of surgery, and the earliest, most common cause is residual viscoelastic behind the IOL, and the late causes, of course, includes the IOL design, the arch, and the axial length. So rotation of more than 10 degrees need to be corrected because it changes the IOL power by 30%. These rotations need to be corrected within 1 week, but of course can be achieved up to 1 month post-operatively. The diagnosis is made on slit lamp, although the 10-degree reticules on the slit lamp limit the accuracy. The other methods of diagnosing a misalignment would be eye trace and online toric result analyzers. With this, we come to the end of section 4, and we will straight away head to section 5, and we'll be announcing the section winners together at the end. So the first question for section 5 is, true about IOL glistening is A, it occurs in hydrophilic IOLs, B, affects contrast sensitivity at both higher and lower order spatial frequency. C, affects contrast sensitivity at higher order spatial frequency. Or D, affects contrast sensitivity at lower order spatial frequency. And your time starts now. And time's up. The correct answer is C. The IOL glistening affects contrast sensitivity at higher order spatial frequency. Now, what are glistenings? Glistenings are basically fluid-filled microvacuoles that can appear within the IOL's optic as early as 1 week after surgery. And they typically grow both in size and density over time. The suspected risk factor is the temperature variations during manufacturing or storage of the IOLs, or the injection molding methods of IOL manufacturing. So basically it is a manufacturing defect of the IOL and is usually seen in hydrophobic IOLs. Now, effect on visual function is actually a matter of controversy. These can cause retinal stray light and light scatter, which negatively affect the vision quality, especially contrast sensitivity at higher order spatial frequency. Coming to second question, all are true for Swan syndrome, except A, happens after a complicated cataract surgery. B, recurrent hyphema is the presenting feature. C, vascularization of wound site is the most common cause. And D, investigation of choice is gonioscopy. And your time starts now. Time's up. And the false statement about Swan syndrome is that it happens after a complicated cataract surgery. So what is Swan syndrome? Swan syndrome is a recurrent intraocular bleeding from a prior cataract wound, which was first described by Swan in 1973. It occurs months to years after uncomplicated cataract surgery involving a scleral incision. Why? Due to a wound neovascularization because of extension of episcleral vessels into cataract wound, likely due to poor wound apposition. The presentation is with intermittent vision loss because of recurrent hyphema. Precipitating factors are minor trauma or straining, or it can also be completely spontaneous. And in rare cases, the visual loss can be accompanied by painful hemolytic glaucoma or angle closure glaucoma. In such cases, gonioscopy reveals wound neovascularization at the prior scleral incision, and the first line of treatment would be gonioscopy lens assisted focal argon laser photocoagulation of the new vessel. It's a rare syndrome. Now, coming to the third question of the fifth section, all are true regarding negative dysphotopsia or NDP, except option A, type 3 shadow is the true NDP shadow. B, angle kappa more than 0.44 mm predisposes to NDP. C, occurs in uncomplicated cataract surgeries. Or D, horizontal width of shadow is 6 to 10 degrees. And your time starts now. This question is taken straight from the study of Dr. Jack T. Holliday. Time's up. And the correct answer is D. The horizontal width of shadow is 6 to 10 degrees. In a negative dysphotopsia, the width of shadow is usually 0 to 6 degrees with a mean of 2.6 degrees. Now, coming to the explanation of it. So, what is negative dysphotopsia? It's basically a phenomena similar to horse blinder, where we have a dark arc on the temporal side of vision. This usually happens after an uncomplicated cataract surgery. Now, Dr. Jack T. Holliday, with the ray tracing technology, showed us that there are 3 types of shadows that are deciphered. The type 1 shadow is caused by the total internal reflection from the IOL. Type 2 shadow is from the anterior sharp IOL edge, and a type 3 shadow is by posterior sharp or truncated lens deformity, and this shadow is the true negative dysphotopsia. Now, in a nominal acrylic pseudophakic eye model with a 2.5 mm diameter pupil, the maximum retinal field angle from rays refracted by IOL is 85.7 degrees, and the minimum field angle for rays missing the optic of IOL going straight away is 88.3 degrees. So this leaves a gap, a temporal dark gap of 2.6 degrees in the extreme temporal field, which is the negative dysphotopsia. Now, angle kappa is the angle between visual axis and the pupillary center. So bigger the angle, herein we're talking in terms of chord length, because it's in the terms of chord length that the angle kappa is usually given in the machines that are there to evaluate angle kappa. So bigger the chord length, that is more than 0.44 mm for angle kappa, or in other words, the more central your pupil is in the cornea away from the visual axis, the higher the chances of negative dysphotopsia. So you have a higher angle kappa, you're going to end up with a negative dysphotopsia. Coming to the fourth question, flap sign is used to predict A, capsular excess extension, B, posterior capsular rent, C, zonular dialysis, or D, none of the above. And your time starts now. This sign is also called as the flap motility sign, and this has been described very recently. So if you people have gone through the journals and you have attended conferences, this sign has been very extensively talked about in the conferences. Time's up, and the correct answer is capsular excess extension. So this flap motility sign is given by Dr. Rohit Om Prakash very recently, and this flap motility sign is to ascertain the extent of capsular excess. Now, if the flap of capsular excess is extended and is everted and fluttering, this indicates that the flap has not extended beyond the equator and phacoemulsification can be safely continued. But if the extended flap becomes inverted on the nucleus and stops fluttering, this indicates that the extension has gone beyond the equator, and this is the end point of any attempts of safe phacoemulsification, and these cases should be converted to ECC or an SICS. Now, why do the flaps which extend beyond the equator invert? Because with the extension beyond the equator, the posterior capsule gets involved. The posterior capsule may get opened up. So there is a negative suction pressure downwards, which along with the increased capsular bag volume due to the phacoprobe, the phacoprobe and the irrigation and the lens volume, the anterior capsule tear is pulled down. So that is why when there is an extension beyond equator, the flap tends to get inverted. And if it is not inverted, we can still attempt a safe rhexis and continue with our phacoemulsification. It's a very useful sign that has been recently described. Now, the last question of this section and the last question of this quiz is lactocruminaceae. Lactocruminaceae occurs in type 1 capsular bag distension syndrome, B, type 2 capsular bag distension syndrome, C, type 3 capsular bag distension syndrome, or D, type 4 capsular bag distension syndrome. Your time starts now. Time's up. And the correct answer is lactocruminaceae is a type 2 capsular bag distension syndrome. Now, what is a capsular bag distension syndrome? It is a syndrome which it is a rare complication happening post-operatively or rarely intraoperatively. Now, post-operatively, there is an accumulation of fluid between the implanted IOL and the posterior capsule in cases where in-bag IOL implantation has been done. So this fluid can be either clear or milky turbid, along with a posterior capsular opacification. In some cases, the posterior capsule may also be clear. So this turbid fluid or a liquefied after cataract, this can cause variable disturbances in the quality of vision and the quantity of vision also. So there are various types to it. Type 1 capsular bag distension syndrome is where a transparent capsule is present and a transparent liquid in the capsular bag is there, which is barely noticeable via slit lamp biomicroscopy, but is clearly seen on the anterior segment OCT. A type 2 is a homogeneous milky fluid in the capsular bag with a transparent posterior capsule, and that is what is called a lactocruminaceae, or a milky white appearance. A type 3 is a transparent or a semi-transparent liquid with a posterior capsular opacification, and a type 4 would be opaque contents with posterior capsular opacification with or without Somering's ring. So with that, we come to the end of section 5. And meanwhile, as the back office people continue to compute the section 4 and section 5 winners, I would take the opportunity to introduce to our viewers, participants, and audiences our third guest for the evening. He is Dr. Rajendra Prasad. He is a proud RPC alumni from AIIMS New Delhi, and he currently is the director and the senior consultant at RPI Institute Research and Training Center, New Delhi. He has multiple innovations to his name, including the terminal chop technique, Terminator, the wedge tool, high dissect for posterior polar cataract, a sewing needle microcapsulotomy, which he is going to be demonstrating in his video today, a T-Soft for soft cataract. He has also won the National Innovator Award 2018 by National Constitution IMA on August 4th, 2018 at Chennai. Has multiple golds: IRSI gold medal 017, UPSOS gold 017, UKSOS gold 2017, Ecoin gold 2015, so on and so forth. He has also won the... Come again, sir?
Please continue, Dr. Bibbhuti.
Yeah, he has also won the best paper in AIOC 017, in IRSI 013, best video in IRSI 019, AIOC in 019, and Roscon in 017. He has numerous paper presentation, video demonstrations, and instruction courses at various international and national platforms like ASCRS, ESCRS, Asia Pacific CRS, APAO, AIOC, and IRSI. And over to his Pearl of the Month, sir.
Hello, everyone.
The backhand office, can you please share the slide
Are
for
you playing or shall I play for you?
Huh?
Sai? Are you playing, Sai?
Yes, sir. They're playing.
To be here with all of you in this beautiful morning. First of all, I'd like to thank Dr. Prashant Bankley for giving me an opportunity to be here in this special episode of Brain Teasers, the online quiz, which is an exemplary educational series which Dr. Prashant has come out with. Now, I think this is one of the series which is most sought after by the PG students, especially those who are preparing for the exams. Now, this episode is especially for the cataract surgery, and I'm going to talk about one of the very important subjects, that is Argentinian flag sign. You all know that Argentinian flag sign is a well-known complication during capsular axis, and it is an early white and the mature white cataracts. We are just pricking the anterior capsule. Your capsule opens up and the tear extends radially to the periphery. And many times this tear may wrap up around the anterior capsule and extend into the posterior capsule, giving us serious complications. So because of its seriousness, the several techniques have been described, including the 26 gauge needle aspiration technique. But believe me, in spite of many techniques, the radial extension of the capsular tear is still continuing to be a challenge to all of us. And if you look at the literature, the incidence of the radial capsular tear extension has been put forward around 28.3% by most of the leading surgeons. But what is important is, out of these 28.3%, almost 7 to 24% of the cases, the anterior capsular tear convert into posterior capsular tear, and which becomes still the very serious problem to all of us. So I'm going to describe a very simple and very swift and very effective technique, saving needle microcapsulotomy to avoid Argentinian flag sign. Now, this is the technique which is going to be published in next issue by the Journal of Cataract and Refractive Surgery. Now, I'm going to show this technique in this pre-recorded video. Argentinian flag sign is a well-known complication during capsular access and intermittent white cataracts, which typically arises instantly after the initial puncture of stretched out tense anterior capsule. Till date, it was known that the raised interlenticular pressure along with forward thrust of the nucleus is solely responsible for the extension of the tear to periphery. To counter this, several techniques including the small needle aspiration technique had been described to decompress the bag, but peripheral extension of the tear has still been frequently seen. And this happens instantly after pricking the capsule, even before initiating the aspiration of the liquid cortex. It means there had to be some other factors responsible, which assist the raised interlenticular pressure to propagate the spreading of the capsule after the initial prick. On extensive surgical evaluation, we came to know that in reality it's not only the raised interlenticular pressure or forward thrust of the nucleus which causes the extension of the tear. It is the configuration of the initial prick made by sharp hypodermic needle on the anterior capsule, which has the potential to spontaneously extend along its open edges. Hypodermic needle or the Rhaxis forceps, while puncturing the anterior capsule, create a linear cut configuration. Linear cut with discontinuous open edges on the tense and stretched out anterior capsule tends to easily open up and split into a complete capsular tear extending to periphery due to the pressure gradient triggering off a disruptive force. Henceforth, we came up with a hypothesis that if we were able to manually create an opening in the anterior capsule which had a round regular configuration like a capsulotomy in true sense instead of a linear cut, we may provide resistance against disruptive forces, thus preventing Argentinian flag sign. Round hole microcapsulotomy help liquefied lens matter to egress out and decompress the bag before initiating the capsular access. To prick the capsule, we developed a novel instrument, sieving needle microcapsulotome with a round pointed tip like a sieving needle system. Sieving needle microcapsulotome, when puncture the anterior capsule, create a round hole opening with smooth margins, unlike the linear cut produced by sharp tip needles. In most of the cases, single microcapsulotomy is sufficient to decompress the bag, but in some cases, multiple microcapsulotomies are required to evacuate the multiple fluid pockets in the lens. To accomplish successful microcapsulotomy, first of all, we need to stain the anterior capsule with 0.06% of trypan blue. Once the staining is complete, then the anterior chamber is injected with cohesive viscoelastic. Then through the main incision, microcapsulotome is inserted into the anterior chamber and punctures the anterior capsule at the center. The hole created by the microcapsulotome helps to egress the interlenticular fluid out from the capsular bag. This can be completed by the milking technique with the help of the viscocannula. Once the decompression of the capsular bag is complete, then the capsular access can be initiated from the central hole and completed successfully. This simple yet highly effective novel tool, sieving needle microcapsulotome, was found to be highly effective and safe to decompress the bag without propagating a radial extension of tear.
Yeah. Thank you so much, Dr. Rajendra Prasad, sir, for a lovely video. It's an excellent innovation, and it's definitely going to help evade the Argentinian flag. Sir, may I please request your esteemed presence in the live platform?
Okay, right.
It's a fantastic innovation, sir. Sir, I have one question with this. So we have seen that despite implementation of various techniques, as you have rightly mentioned in your own video, that essentially work on the same principle of decompression, we often see a flag nonetheless in cases where not much of liquid cortex comes out, and there is a large nucleus present. In them, the high ILP actually is caused by the liquefied cortex that goes behind the nucleus, and that tenses up the bag, and that is why the maneuvers used to decompress the bag from anteriorly essentially fails, as the perpetrator is the main, and the perpetrator is behind the lens, actually behind the nucleus. So how do we tackle such cases where we suspect a high ILP, a large nucleus, and a possibility of a flag sign, and intraoperatively scant fluid egress is seen in spite of implementing a decompression strategy like maybe your sewing microcapsulotomy or others that you have described that usually eventually also have some failures. So how do we tackle such cases?
See, first of all, this technique is a very simple technique because you don't have to do too much of manipulation like what has been described, especially like puncturexis, laser capsulotomy, because you have to use a difficult procedure, because here you need just a simple needle, and which is similar to the sewing needle. It has to be a very sharp needle. You need to just puncture the entire capsule, and it gives a microcapsulotomy kind of formation in the capsule, which has a strength and resistance against the pressure which is there in the intraventricular space. The simplicity and its effectivity is important. Now, as you have asked, what happens if you don't have a fluid in the intraventricular space? It's just a fluffy cortical material. Dr. Dhami has very nicely published one paper recently, because the use of the anterior segment OCT, where you could find out the fluid pockets in the intraventricular space, whether the fluid pockets are one or multiple fluid pockets or no fluid pockets also. So you can do anterior segment OCT to know that whether really the fluid is there or it's just the swollen cortical material. If you have a swollen cortical material, then of course, because this technique may not work, and you have to opt for the other techniques, like where we do a single stage spiraling technique, or very microcapsulorhexis we do at the center, and then try to evacuate this fluffy material out of the capsular bag. And you can carry on with the completed access later on at the stage also. But here in this particular technique, if you find most of the cases, you have the fluid pockets. And the fluid pockets, like what happens, even a single puncture, if you are able to evacuate 2 to 3 drops or even the 2 drops of the liquid out of the capsular bag, the capsule becomes relaxed, because the decompression happens even with the 2 drops of the fluid coming out. And the fluid pockets in a swollen lens, especially in the intermittent cataract, you have 2 pockets. You have an anterior pocket and then the posterior to the nucleus, which is between the nucleus and the posterior capsule. And generally, these cases have a firm cortical material at the equator, so which separates these two pockets. But as I said, because if you are able to evacuate the anterior pocket, your capsular decompression happens and you can very simply carry on the capsular axis. But in some cases, like if the fluid is more in the posterior pocket, then you just do few punctures and try to press the nucleus posteriorly. Many times when you press the nucleus posteriorly, the posterior fluid would start coming out into the anterior segment, anterior pocket, and then you can evacuate it. And the very doctor from the Singapore very nicely explained about the use of the milking technique, where you can use a air cannula or you can use a visco cannula, go to the periphery, press the nucleus and milk it out. You can milk out the fluid from the capsulotomy, which we have made at the center. This technique actually is a very simple technique and it works very well. And you just need a very simple needle and just puncture the capsule. And you can generally one puncture is enough. But sometimes if you see the multiple pockets, then you can do multiple punctures. But it has these punctures has to be within the 5 millimeter of the radius of the center nucleus, and so that you can create a capsular axis of 5.5 millimeter or 6 millimeter.
Sir, we can have comments from Dr. Jeevan Titial. Titial sir, can you comment on this technique? You are another master in the phacoemulsification and in pediatric cataracts. Titial?
Thank you, Prashant. Dr. Rajendra Prasad has shown a wonderful technique in a wide cataracts. It does work out if you do a small opening in the anterior capsule in difficult cases like this. As many people would have seen my presentations also earlier, we have described the spectrum of wide cataracts with intraop OCT or ASOCT in these cases, and we have classified them accordingly. So if you know what type of wide cataract you are facing, then you can plan your surgical steps for a capsulotomy or capsular access accordingly. As rightly described by Dr. Rajendra Prasad, it is those cases where you have pockets which are underneath the hydrated cortical fibers, which doesn't get released even after you make an opening in the anterior capsule, and intralenticular pressure still remains even after opening the capsule in these cases. These are cases you have a very high chance of peripheral extension. But in those cases where you have a totally fluid-filled cataract, which you have what Dr. RP was talking about, those are cases as soon as you make a puncture, either the fluid will leak out with a significant flow, or you have a very little fluid. So those cases you have a chance of extension. I rightly pointed out the major teaching for these cases are to maintain the anterior chamber pressure uniformly during your capsular access procedure. And that can only happen if your viscoelastic doesn't leak out. And you maintain the pressure on the anterior capsule from the center to periphery. So what nowadays I talk about to my student to maintain a viscoelastic which remains in the anterior chamber. So first you have to put a dispersive viscoelastic. Then over that you have to put a cohesive viscoelastic. So what cohesive viscoelastic will maintain the chamber. A dispersive will never leak out when you try to draw the fluid in these cases. Because what happens if you have milky fluid, you tend to press your wound area to take out the milky fluid out. In that process, your capsular pressure changes. And that is the time the extension can happen in these cases. So if you use a combination of viscoelastic, which is a new concept in all these difficult scenarios, you can maintain the pressure in the periphery also, especially when you feel your peripheral area, because once you make a central opening, the lens nucleus bulges upwards. And there's a more pressure towards the mid-peri or peripheral area. So that is where you require a pressurized dispersive viscoelastic. But I think if you make a small opening, if you have a raised lenticular pressure, you can aspirate by a needle, you can aspirate by a bimanual cannula, then see how effectively you decrease the pressure, then you can do our access very, very comfortably. So most of the time, it has to be a two-stage capsular access in these cases of intumescent wide cataracts.
Okay, meanwhile, we continue with the discussion. Bibbhuti and Divakant, can you declare the section 4 or 5 winners so that they can join us on the Zoom platform as well as the runner on your chat box?
Sure, sir. Dr. Bibbhuti will be declaring the 4-5 segment winners. Please.
Yes, sir. So the winner of section 4 is Dr. Kabita from New Delhi. Congratulations, Dr. Kabita. And the winner for section 5 is someone for a change who is not from Delhi and who is not from RP Center. She is Dr. Zeba Sheikh from Pondicherry, section 5. Congratulations, Dr. Zeba and Dr. Kabita. Both the winners and all the section winners will be getting a link on the registered mobile number, and we request them to join in the Zoom meeting to have an interaction with our experts and to get felicitated. Over to you, Prashant sir and Divakant sir.
Divakant.
So let's declare the runner-up for today's session. So it's Dr. Shehnaz Anzum from Hyderabad. Congratulations, Dr. Shehnaz. And the winner for today's session is Dr. Vishal Thakkar from Ahmedabad.
So,
Congratulations. I hope everybody can join soon so that we can
so
start.
meanwhile, we can continue with our discussion, and one last technical question. After that, we can have some non-ophthalmic chat with the guests who are with us. So over to you, Bibbhuti and Divakant.
Yeah, sir, I am done with the question. My set of questions with Dr. Rajendra Prasad, sir. I think it's an excellent innovation, and Devakant, sir, if you can.
Let me put one thing there. I think, can you hear me?
Yes, sir. Yes, sir.
Yes, sir.
I think Rajendra Prasad did mention if you use a femtosecond laser devices in these white cataracts, it can always ease out your chances of having a Argentinian flag. Till date, there has been no description of a Argentinian flag with a femtosecond laser capsulotomy, because you do have micro additions remaining in these cases, but you can still complete those rexes because by the time you open the chamber, the pressure has gone. So femtosecond laser is a definite safety in cases with intermittent white cataracts.
So, but for a underprivileged surgeons like us, we would look up at Dr. Rajendra Prasad, sir.
Yeah, that is true. That is true. But this is a forum for young people, and young people have to adapt to newer things because I am fully convinced the future is all technology. And today we are off microscope. Tomorrow you'll be sitting in your office and doing the surgeries also.
Yes, robotics.
Yeah, yeah.
And if Prashant sir is underprivileged, then I don't know in which category to be.
That's true.
Okay. So now it's time for Beyond Ophthalmology. We have privileged guests with us, Dr. Titiyal sir and Dr. Rajendra Prasad sir. So this is something a chat beyond ophthalmology. So first
to be in such a wonderful year 2021, both Rajendra Prasad and I am from the same state. We belong to the same place.
I was about to ask you, both of you, sir.
From the same institute also. Dr. Titiyal was when I was senior resident, he was my junior resident.
That's correct. That's correct.
सर ऐसा क्या है हिमाचल में कि सबके सभी लोग बड़े लोग टॉप मोस्ट लोग आप लोग सब ऐसे ऑप्थेल्मोलॉजी के बड़े राइजिंग स्टार्स luminating stars are there. You both.
We are from Uttarakhand, not Himachal.
Yeah.
We both are from Uttarakhand.
सर एक ही है, सब ठंडे एरिया में आदमी को थोड़ा सा ज्यादा ब्रेनी पीजीआई चंडीगढ़ के हेड भी देखिए, डायरेक्टर साहब भी आप ही के हिमाचल के, हम लोअर लाइंग एरियाज के लोगों को कोई ऐसा थोड़ा सा कम IQ है क्या? I don't know. Whatever be it, sir. How was your journey from, I should say, from Uttarakhand to Delhi? Both of you, either of you can answer, sir. And where is your final love for Uttarakhand or stay at Delhi?
See, I actually belong to a very small place in district Uttarkashi of Uttarakhand that is called as a Harsil. Harsil, you must have heard it. It has become a very important tourist place now at present, and because of many reasons, it's one of the biggest army base of Uttarakhand along the China border, and the place where I live called as Harsil, which is hardly 60 to 70 kilometers from the China border. So I did my basic education in that place, and where we had to walk almost 5 kilometers to reach the school every day morning, and it's a very cold place, full of snow. Now in winters you can't walk even because there's almost 8 to 10 feet snow there now at present, and even in summers also it's very cold. So that was my basic education, and but I had a zeal to study from the beginning itself. My elder brother was a teacher in a basic school there, so I used to live with him, and from there then I did my MBBS from the Jhansi Medical College in UP through the UP entrance of medical entrance. And then after completing the MBBS from Jhansi, then I took up the examination for the All India Institute, and I got selected there for the MD. So I did my MD and residency over there. But I always had a mind not to do the government job. I always wanted to come in the private practice. So I took up the private practice. But what you can say, because without any support and with a zero, you can say, base in the Delhi, because we don't have any forefathers or something like which you could they could help, because even I was living in a rented house for a very long time, almost 10 years in a rented house, and started a very small clinic with a very small gadgets of ophthalmoscope and tonometer like that. So slowly I build up my practice and my center also. Now we have three centers in Delhi, full three centers, and these centers are fully equipped with all the latest equipments, and we are doing all research work. We have a complete team of 15 to 20 people, and doing all sort of surgeries and giving the best possible facilities for the patients. And we are doing over that, we are doing a lot of community services. I go every year to my state and do eye camps, which includes the screening eye camp as well as the surgical eye camp. And I've done in a remote places like called as a Badrinath. You know, the Badrinath Dham. We have did a very big camp there, and we operated almost 50 cases there also few years back. And we keep on doing a lot of community services for our state because that is my heart. Without my state, because I every moment of my life I remember the place from where I have come. Thank you.
Thank you, sir. It's such a humble beginning, and where you have reached destination, it is for our young viewers who are watching us to ape and follow. Titiyal sir, over to you there. आप भी ऐसे ही कोई छोटे से I remember in one of the Uttarakhand meeting you shared with me that your village is somewhere down there. Yeah, and you came up there, and from there you have risen up to the ranks of being a Padma Shri, awarded Padma Shri. How do you look at this journey, sir? How tough?
I think, it was, I think some people are born lucky, I think. And I've been one of the luckiest person as far as I am concerned. I have a similar background as what Dr. Rajendra Prasad talked about. I really congratulate him doing a wonderful work in his career, building his institution in Delhi and getting his children into that also, and doing wonderful service to our local people. And we are fortunate sitting in Delhi. And it's not only we are serving the people of Delhi, we are serving our people from our community also, Uttarakhand. And biggest service which I have done in my life is, to serve my own people in a difficult situation in Delhi, getting them treated in AIMS. That's one of the biggest thing which I have done for my own people. Secondly, I am very proud that I'm in a place where I started my medical journey. I became a student and postgraduate and became a faculty. And having that opportunity is very, very rare to people, to have so many students going through you, and they are the your own vision, your image. They carry forward to various parts of the world. So that's a really, I think, very, very lucky to have a situation like that to somebody, and I'm very fortunate with that. My village is also very, very small. As he said, we used to walk almost 2-3 days to reach a primary school and then middle school. But fortunately, my father was in Lucknow for some time, so I had to come to Lucknow for my 12th. There I knew that there is an institution called AIMS, and luckily I got into that also. And just one story, how I became an ophthalmologist is a story also. During my internship, I was in a village posting, a place called Ballabgarh in Haryana, which is AIMS peripheral area. One of my senior resident surgery, he gave me some surgery during my internship. And he told me, you have a very nice hand, why don't you become a surgeon? So I opted for surgery as my first choice for a post-graduation. But unfortunately, I could not get in a first attempt. And in second attempt also, I had to take a second choice. That was my ophthalmology. And that is how I got into ophthalmology. And one of my junior, who is a cardiologist now in Himachal Pradesh, he told me, yeah, why don't you join ophthalmology? Because single-handedly you can do everything. You can do a medicine practice, you can do surgery also. You don't require a anesthetist help also. And that's a very good branch. And you are little, you're not that person who can go around and put your weight for things. It's very good for you. And I nearly joined a railway service at that time, so I still give it to my friend, colleague, and he's in Himachal now, who pushed me into this area, and appreciate my teachers who really at my residency also during my junior residency they used to tell me you have a very good surgical hand, and that would give you a encouragement to anybody. That is how I appreciate my students also. I'll always pick up students good things, but appreciate their good attitude, good approach to a particular situation, clinical case or surgery wise also. And working with young people, I think that's the opportunity many of us don't have, because they have a good mind, good thinking. They know the how to get best out of a situation, and that's how we have so many publications from RP Center, so many techniques, so many patients we take care of. I think Prashant, you will realize technology comes because it's a demand of not us, a demand of the people who are going to go through us with the training. For them only we have to work and we have to establish things. And ultimately, I'm very fortunate that I have so much large number of patients coming to us, because if they are there, we are there. So these two people, my students and my patient, have given me this, you can say, name, which I always indebted to my institution, my teachers and my students. In fact, I would say if they are there, I'm there. So thank you for this platform, talking in front of young people.
Thank you, Titial sir. In fact, you are such a proud teacher, and we have today young Bibbhuti as your proud student over here. So he was also sharing some good thoughts about you when we started planning for this session for this month, January. And that's how you are with us, sir. So guys, all the viewers, young guys, listen. It is not that you need a pedestal to become a Padma Shri or have an institute, 3 institutes in a city like Delhi. You need to have a zeal, you need to have a determination, you need to have a focus. So please do not use it as an excuse. It is the sheer grit of these two people who are sharing the stage with you, that they are at their respective destinations, which we all would love to emulate. So with this, we come to the end of the chat, and it is time for us to felicitate our winners, sir. So Sai, do we have all the people who are winners today on the platform?
Almost one, everybody else is there.
Yeah, okay. So we start with the felicitation ceremony. So the first section 1 winner, please over Divakant, you have to announce, and Dr. Titial sir will be interacting and virtually handing over the prize to him. Yeah.
So the section 1 winner is Dr. Sohini Mandal from New Delhi.
Yeah, Dr. Sohini, are you there?
Yes, sir.
Please
Thank
put
you,
on the video. Congratulations. And
Thank
this virtual gift voucher by Dr. Titial sir, and a few questions to her, non-ophthalmic sir.
Sony, wonderful. Congratulations. I SMS you before you had this, 1,500 in your hand, and I'm pretty sure you'll treat us tomorrow in the OT. Let's have a cake from your side.
Yes, sir. Definitely, sir.
Congratulations.
It was a difficult section, Prashant, looking for young people, asking them a history of cataract, and they would have never seen ICC in their life also. But she done a good job there. Congratulations, Sony. Wonderful.
Thank
So
you.
you need to remember, this is from a UC president who represents the younger blood like you. Okay. Divakant who had strategized this particular history. So you can either curse him or you can pat him for whatever it has happened for you. Congratulations once more.
Thank you so much.
So now the section 2 winner, Bibbhuti, declare करिए and उनको Dr. Titial sir ही felicitate करेंगे.
The second winner of section 2 is Dr. Ayushi Sinha from AIMS, New Delhi. Sir, to please do the honors.
Yeah,
Yeah, Ayushi, are you there?
Yes, I am.
Again, congratulations, beta, and very proud that you could do a justice to your training in RP Center, and very nice to see you there. And you also have won 1,500 rupees. This is nothing, It is the your way of accepting these learning and replicating time and time, winning various quiz awards. That's very nice, and keep it up.
Thank
And
you.
wish you much more laurels in the future.
Thank you, sir.
आयुषी, आप कॉर्निया वाले हो कि क्या बनने वाले हो? अभी कौन से ईयर में हो?
Sir, I just completed. I am in 6th semester. I just gave my MD exams.
So what do
She
you plan?
just cleared the exam.
Okay.
Good.
So what do you
looking
plan?
she'll be looking for senior residency now.
Yes, to appear in the exams.
Very soon.
Specialty which you have developed love in last 6 semesters?
I really enjoyed my cornea posting. I really enjoyed my refractive posting. I was posted with sir also. So I got the opportunity to see him operate as well. So I really liked all that. I have enjoyed the entire course of RP Center, so retina as well. So I'm kind of confused in what I want the most. Let us see.
भाई देखो, प्रोफेसर अतुल कुमार सर भी सुन रहे हैं और इधर जीवन सर भी सुन रहे हैं. आप बता दो आपकी चॉइस क्या है?
उसने दोनों बताया ना. She is very smart.
Thank you. Congratulations, Ayushi. Now let's go to the section 3 winner. So, Divakant, you have to declare.
Section 3 winner is Dr. Prerna from Varda. Are you
Dr. Rajendra Prasad, sir, you are going to virtually hand over the voucher and felicitate her and interact with her. Dr. Prerna, are you there?
Yes, sir.
Put on your audio video. Yeah.
Yes, sir. I already.
Yeah.
Yes. Yes, Dr. Prerna, congratulations.
Thank you, sir.
And it's a wonderful feeling. Like, I'm really thrilled for you winning this kind of platform, because this gives you how spirited you are actually. So this is something like one student at this age or of the ophthalmologist of your age should be into. So it's a wonderful feeling, and congratulations to you. And
Thank
this
you.
gift of 1,500 Dr. Prashant has given to you, and will be handed over to you later on. Okay.
Yes.
So wonderful. Congratulations. Congratulations.
Now, section 4. The winner of section 4 is Dr. Kavita Tiwari from New Delhi, AIMS New Delhi. Sir, to please do the honors.
Is she there? Kavita, you are there?
Yes, sir. I am here.
Kavita, again, congratulations winning this.
Thank you,
How do you feel winning a quiz like this?
Obviously, it feels very good.
That's very nice, and keep it up and keep working, and next time win the top prize.
Thank you, sir. Definitely, sir.
Good.
Okay. Thank you, sir.
Yeah, I'm sorry. Yeah, please go ahead.
Yeah, and the winner for section 5 is Dr. Zeba Sheikh from Pondicherry. Congratulations, Dr. Zeba. Rajendra Prasad, sir, to please do the honors.
Hello, Zeba.
Hello, sir.
First of all, congratulations to you for winning this session of the brain teasers, and which is, I think, is getting very popular amongst the young students, and the people like you are coming up, participating in this platform and winning this. It's a great feeling, and it's really congratulations to you. And
Thank you.
You are exactly from which place, you said?
Sir, I'm studying in Pondicherry, sir.
So you are in Pondicherry. Okay, that's great.
Yes, sir. Thank you.
And
Is she the Tiwari from which place? Bihar?
Sorry.
So you belong to which state?
Sir, I belong to Ahmedabad basically, but I'm
Acha.
studying, pursuing my MS from Pondicherry.
Jipmer?
No, sir, Mahatma Gandhi, sir.
Mahatma Gandhi. Okay, good. Keep it up.
Thank
Keep
you,
it up.
sir.
So congratulations, Dr. Zeba. And now over to section winners. Section winners.
सारे लड़कियां जीते हुए क्या बात है?
हाँ sir.
They are super intelligent.
See, we all are on the podium. We are all males. We need to really ponder what we should be doing.
Best is for the last.
Yeah.
So the runner-up we have Dr. Shehnaz Anjum from Hyderabad. Rajendra Prasad sir to do the honors, please.
Hello, Sehnaz. Are you there?
Yes, sir. I'm here, sir.
I can't see your video. Okay. Congratulations and for winning this session of brain teasers.
Thank you.
And
Sir.
you are runner-up, and it's a great feeling for you.
Yes, sir.
Really, congratulations, and please keep it up. And
Thank you.
next time you should come up on the top.
Yes, sir. I'm also from RP Center, sir, and I have also learned from Tityal, sir, and all other. Sir.
Very nice, nice.
Yes,
When
sir.
did you pass out from the RP Center?
Sir, last year, sir.
Last year. And now where you're settled?
Sir, I'm in Hyderabad right now, so I haven't joined any fellowship, so I'm just looking for. Yes, sir.
Okay, you'll be joining the fellowship.
Yes, sir.
That's good.
Sena, you have been wonderful during your stay in RP Center. I still remember you.
Thank you so much, sir. It's an honor for me, sir.
Shehnaz, congratulations. Seriously, it's a clean sweep from RPC this time. Our invited guest list has provoked, or rather invoked all the people to be participating, all RPC alumni only participating. Congratulations once more. And keep it up.
Really proud of RP Center, and because the students coming up under Dr. Tityal, I'm really proud of, because being from RP Center, and it gives a great feeling that our students are winning everything.
Congratulations.
Thank you, sir. Thank
So
you, sir.
the final prize today. Yes, go ahead.
So the big winner for today is Dr. Vishal Thakkar from Ahmedabad.
Vishal, are you there?
Yes, sir, I'm here.
Just put on your video on.
It's already on, sir.
Yeah, great. So,
hello, Vishal.
Hello, sir.
How are you today?
Sir, I'm very good, sir.
Vishal,
what's your...
No, sir, I'm not from RP Center. Actually, I still want to pursue senior residency from RP Center. I already wrote the last exam. I'm also writing exam this time.
Okay,
unfortunately, I couldn't get last time. I got only one less mark from the cutoff. So
we wish you all the best, and may God help you this time to get into RP Center.
Thank you, sir.
And Vishal, what's your feeling winning the coveted first prize?
So it's really wonderful. It's an amazing opportunity to hear to such stalwarts like you, sir. We have learned so much from you, watching your videos and reading your publications in JCRS, and I really want to pursue cornea and cataract training in RP Center. If
your basic education medical from which place?
Sir, I'm from Ahmedabad, and UG and PG I've done from Municipal Medical College at Ahmedabad.
Okay. You're pure Ahmedabadi, huh?
Yes, sir.
So something you say in Gujarati to us?
You are happy, you can say that.
Came chair.
How much, sir?
Vishal, as I strongly feel, my own entire teaching career of now extending more than 30 years, I always think that the younger people should come up with better ideas, and those ideas will take us to we and the entire society will take us to a brighter future. A brighter future for us is a brighter vision, and the vision will come from better corrections. And that can only possible if you have a knowledge, and you translate your knowledge to the skill which ultimately translate to a patient's care. So again, wish you all the best, Vishal. Hope to see you in RP Center.
Thank you, sir.
Vishal, congratulations once more. पर अगर आप बोल देते कि देखो भाई, दो co-host भी रेटिना वाले हैं, मेन होस्ट इज आल्सो रेटिना, अगर बोल देते रेटिना वाले हैं तो मैं ततियाल सर को थोड़ा सा पुश लगा देता आपके बिया, पर आपने कॉर्निया बोल के हमें नाराज कर दिया. By the way, congratulations, keep it up. You should do whatever your passion you have for, and we wish you all the best. So we come to the conclusion of today's event, that is episode 8. I'm really thankful to all the participants who participated in a big number. And I congratulate all the section as well as session winners. And my special gratitude to the invitees, invited guests who could spare time, that is Dr. Rajendra Prasad sir, Dr. Titial sir, Dr. Harsha Bhattacharya ji sir, for sparing time for our small event, that is Brain Teasers. In fact, this Brain Teasers, we invite guests like you because you are the people who the younger generation looks up at, and you have been an inspiration to even our generation. So sir, keep inspiring us, and we would definitely love to see you more so on our platforms to keep inspiring our younger new generations.
Definitely, Prashant. And don't say it's a small. You have made it a big, program. I've been seeing your programs, listening to your quizzes. My students are winning also in a previous episodes also. And two young people, both Divakant and my own student Kashyap. They were very nice. You can say the way they put up questions, and it is like our case presentation. What we do first, you have a case, then explain, then discuss. Very nicely done, and that is what I think quiz should be. Ultimately, the basic part, the basis of generation of that question, and the basis of answering that question correctly should also be told to young generation. And your people are done. The young people have done wonderful job.
Yes,
congratulations,
sir.
And see you again.
Yes, sir. I'm only a catalyst. In fact, basically, it is these two young Turks who did the job. They did the questions. We provoked them to do all those things, and they really do hard work along with my colleague, Dr. Shilpi.
Shilpi also.
She does all those things. So we are really thankful, Diva, as well as Bibbhuti, for wonderful efforts, and it is appreciated by one and all. So congratulations. And also, I would like to thank Entod for this opportunity, for sponsoring us with all the prizes, and for this financial support for keeping our Brain Teasers live. Thank you. And to the back-end office, Sai and his Numerotech team, once more. Thank you. And we are meeting again on 7th of February for our next episode. That is episode number 9 on 7th of February at the same time. So till then, bye-bye, and wish you all a happy new year and a spirited new year. Thank you. Thank you, sir. Thank you.
Thank you, Prashant, and congratulations to you for bringing up this beautiful platform for the young students. And I think this program has become talk of the town. It's
Thank you.
really appreciable. And Bibbhuti and Divakant, you both have done excellent and wonderful work today, and I've seen your capability, and it's really appreciable.
Thank you.
Thank you very much.
Divakant has that Lucknowi touch, the way he speaks, very, typical, nice way. That I like it, very nice. And Bibbhuti has typical that, Ranchi style. Both of them have different styles. Very, very, very nice.
Thank you, sir.
Lucknow is my second home, Divakant.
Where did you study? So you mentioned
I was in a small place called National College, which is Hazratganj. I did my 12th from there. Then I did a 1-year coaching in Ahmedabad, Krishna coaching at that time. It was one of the famous coaching center of UP those days, medical coaching.
Yes.
I still remember my geology and botany and physics teachers. Because of them only I could get into AIMS, Otherwise, as Dr. Rajendra Prasad would know, we used to write in Hindi and speak Hindi only. Yeah. And I didn't know how to write in English the entire biology, physics, and chemistry. And the AIMS exam was, those days was a theory exam. You have to write in English. Yeah. And because of that 1-year coaching, I could do everything. Yeah. So that's a wonderful platform.
Dr. Titial had at least some opportunity because his father was in a very good job, and he had access to Lucknow and all, because I never had anything. My father was a very small scale farmer, He was not working government job. So I'll just tell you